We now move on to our next scientific session, that is invasive fungal infection. And I would like to invite the chairperson for the session, Dr. Ruchi Gupta, on the stage, please, and Dr. Manish Bharti. Kindly do the honors again, sir.
So, yeah. So it's my proud privilege to introduce the next speaker. He's my teacher mentor, Dr. Dhruv Chaudhary. He's professor in head pulmonary and critical care medicine. He's a professor research at Rohtak, and he's a member of Lancet India Task Force on COVID-19. He's a president, Association of Commonwealth Scholars and Fellows. He's a state nodal officer, Haryana COVID-19, past president, IACCM. So many extraordinary stuff, which all belongs to Dr. Dhruv Chaudhary. I welcome you, sir, on the behalf of First Onco Critical Care Conference 2023.
Thank you, Manish and Rich. Next 20 minutes shall be talking about invasive fungal infection. Thank you very much for giving me time out for this particular topic. So we have reviewed it. Most of the time one has been talking about ventilation, electrolytes, blood gases, etc. So I'm extremely thankful for that. And right at the beginning, I would like to thank my DM fellows, particularly Dr. Jyoti, Geeta Kumar, who helped me preparing it. But at the same time, I have borrowed a lot from Medscape, and because they had a couple of series which have come up on invasive fungal infection, and I found out there's nothing better than that. There's no need to reinvent a wheel when things are there. That's what I am studying right in the beginning. And over next 20 minutes, what we understand about it, and there's a lot of talk about, and there's a lot of buzz. And what we see quite often is that patients are being sent us back to us. What we are admitting is one part. At Rohtak, we have a very flourishing and exploding private sector. From there, we, after 5th day, we start getting the patients. And same is happening from the NCR. When the people run out of their pockets, the money, again, the pressure is on us. So practically each day, we are shifting in the hospital around about 2 to 3 cases from NCR or from local because of financial reasons. Nobody comes and said we have not been taken care of. But nevertheless, when they start coming up, what we are seeing is that gradually the fauna and flora of those places has started coming to our intensive care units, which we never used to see earlier. And out of them, obviously invasive fungal infections is becoming more and more. And same thing is happening in the pediatric intensive care unit. Same thing is happening in the neonatal intensive care unit. We have a huge neonatal intensive, 72 beds. And that's what we are looking at it at that place. And pediatric intensive care now has been added up 50 beds, and adult have gone up to now 100 plus. Though I look after my small ICU, but we have expanded a lot during COVID and all, and it has created its own challenges and problems. So we are looking at our policy. So that way, I'm grateful that this topic has been given for us to review it. And the question starts is when we look at it, what is invasive fungal infections? As a pulmonologist, as an internist, I do keep on seeing a lot of them as far as the respiratory practice is concerned, and particularly chronic aspergillosis, which we used to see in mycetoma, but we know there are multiple other forms which people have been treating as a TB, turning out to be actually chronic necrotizing pulmonary aspergillosis. And with the more and more use of change of pattern of practice, incidence has gone up. And that's why you will see whenever you will read invasive fungal infections, people will be talking about repeatedly pulmonary aspergillosis, but I will not be discussing it here because that is a topic in itself. I was wondering how to put everything in 15 to 20 minutes, so bear with me, and we'll be more than happy to answer any questions if they will be there. So let's look at it as a time-tested definition: severe systemic infection with yeast or molds. There's a bit of a difference between two of them, so but that's not my talk today. And this is epidemiology of burden of invasive fungal infections, which is across the world, which has been published in Journal of Fungi, and you will see it. The blue is the area where we don't know what is the data, but the one which is the light green, which includes the Asia, that is the South Asia, we ourselves as well as the China. What we are finding is the total data in 2017 is not, and today even if you see it, it will be not much difference, is that nearly 3 lakh cases are of chronic pulmonary aspergillosis. That's what I was talking about. And with the TB and then the slow grade liquid which is happening, which people used to start ATT, actually 83, more than 3/4 are not recurrences but are the CPA. That's what we look at it. You have a cryptococcal meningitis. Dominantly, it came in our jargon with the HIV. Continue to see where steroids are there, or you may have a severe immunosuppression. So threshold has to be high. If there is a headache, you need to look for it. You have a systemic candidiasis or invasive candidiasis, which is becoming a huge problem. Then we also have invasive aspergillosis and so forth. And also fungal asthma, like we see, we are doing 2 trials now on ABPA, that every week we are seeing on an average 2 new cases of ABPA being detected. And we did a study where we find out 13% of our asthmatics actually have sensitization to aspergillosis. So it's nothing unusual. The only question is, when I started looking at it, we started finding it out. So what your brain doesn't know, the eyes don't see. And that's what is happening today with the expansion of the knowledge. Now, when you are defining invasive lung fungal infection, there are different tests, different hosts, different pathogens. I think that this slide beautifully explains what we are looking at it. We have the tests, we look at histopathological examinations. We look at a direct microscopy, obviously, but along with it, there is an important, is the culture and the molecular diagnostics have their own sensitivity, but we need to look at it, how we are going to interpret them. And there are an indirect test or the serological test where you are looking at the biomarkers, which include beta-D-glucan, galactomannan, and Calgata, etc., which will be there. Host has changed, and it has changed because of advances in medical sciences, and that's what we are looking here is hematological and other immunocompromised people, pediatric groups, and patients in intensive care. We're all talking in terms of immunosuppression in the clinical terms. But if you look at the definition of sepsis today, it is immune senescence. It's a dysregulated immune responses. And what we are seeing is, if you don't recover, a certain set of people go into the late sepsis, and that is what you are finding it up. There you are finding reversals of ratios which are there of the T cells and neutrophils and lymphocytes, and they are having more mortality, more morbidity, and as immune senescence sets in, you see the incidence of fungal infections in intensive care units also go up. Pathogens are different, you need to identify, drugs may be different, but gradually we are going again to a more secular trend because of the presence of the drug resistance which has started coming up and we have started talking about. You may have a candida, you may have a aspergillosis, cryptococcosis, pneumocystis, we keep on seeing it off and on. At my center, at Rohtak, we are the state ART center. We have more than 20,000 HIV patients enrolled in that hospital. Now they are being disseminated, and we are seeing right now itself, I have 2 HIV with PCP lying in my intensive care units. So we are seeing a huge burden which is there across, but nevertheless there are big 4. And the big 4 are candida, aspergillosis, then along with it you have a mucor, and the 4th one is your cryptococcosis. These are the 4 big ones we keep on seeing is invasive disease. When you are looking at it, a prevalence worldwide, it is the most common invasive fungal infection. That's what we are seeing it. Followed by, in terms of molds, it is aspergillosis, followed by mucor, which is there. And all of us saw the epidemic of mucormycosis during the time of COVID. But if it was a cyno-orbital, technically it is not called as invasive fungal infection. But the lung we have been seeing, I'm astonished to see the number of invasive lung infections which we have started seeing fungal infections over last 1.5 years. Never had seen that much. And also right at this point of time, 2 patients of invasive or the mucor are lying with us, and we have got pneumonectomies or lobectomies done for these cases. Now, risk groups are important, commonly identified. All of us know patients who have leukemias, who have some stem cell transplantation or the solid organ transplant, etc. What we are also seeing is the lung transplant recipients, obviously aspergillosis is much more, and it is now starting picking up. in our country, and obviously in the north now it has been started in the right earnest in some centers. But what is very important is the emerging groups which you are looking at it. Chronic pulmonary disease, please look at it. Anybody who has a COPD must have received steroids and must have some amount of colonization with it. If you have a bronchiectasis, incidence is much higher. Person having a sinopulmonary diseases or sinonasal sinuses, again you can have allergic rhinitis where you can have a high incidence of aspergillosis which can cause it. Lymphoproliferative disorders, and what we are interested today is in terms of intensive care units. Now we saw the new terminologies coming at in influenza and COVID, that is what is kappa, what is influenza associated aspergillosis, or we also saw that COVID associated mucormycosis, and we published a Delphi series along with Professor Anurloke and 26 people in Lancet, which was accepted. Now if you see, the most important thing in intensive care continues to be your Candida and aspergillosis. I think these are the two things which you need to look at it. And hemetic transplantation, the blue one tells you about invasive aspergillosis, and the red one is about candidiasis. And here you will see that again a very high chunk of these patients, the blue ones, tends to be the aspergillosis, and the maroon one is actually candidiasis. Same thing in this study, the solid organ transplant. The blue one you will see is actually coming up. There's a bit of a difference. So hematologically you are seeing more of aspergillosis, whereas in a solid organ transplant all these blue things you are seeing primarily is because of Candida. So there is important for us to remember is that probably in the organ transplant, so if you have a significant neutrophilic dysfunction, probability of getting aspergillosis or mucor with acidosis or with an iron overload is much higher with mucor. I think these are the few things which we need to look at it. That's why people have tried also chelating therapies in mucor so that iron which is required may not be given to them. Then obviously let's look at the Indian scenario. This is the paper published in the Fungal from All India Institute of Medical Sciences, and they found out the incidence was 7.6% of the invasive, and this is over a period of 18 months, nearly 3,300 patients, and they found out that 253 had a fungal infections. In this, they have been defining it up as a proven, probable, then they are looking possible. So all these things grades have been there. So the proven are where you have documented, and again here you will see it, that hematological malignancy is there. It's across the board. It was in the whole of the All India Institute of Medical Sciences, Delhi, but nevertheless we found out candidemia, invasive aspergillosis, cryptococcosis, and mucor were the common ones which are there. And among the lung involvement, what they found was the commonest, followed by the bloodstream, which we use it actually to define invasive fungal infections. And albicans and paracellosis are the commonest ones which they are seeing. And they also find that 30-day mortality was nearly 43%, which is very high. Again, obviously underlying disease where you are getting it is contributing to it, and highest it was for the invasive candidiasis, followed and cryptococcosis, because HIV, another thing you had meningitis, which took time. And again, you are finding, which is very important, is high MIC levels of azoles and other antifungals. That means we are looking and glaring at the high incidence of drug resistance to the azoles, and therefore they may not be the primary source of management for us if looking at the sick patients. Echinocandins, also few of them, especially capsofungin, we are seeing a little high MIC values. So there is a shift in epidemiology in our country, and we are following now the Western pattern which has been there. And now I will just like to share this PJ Chandigarh data, autopsies where we have been all trained, is that autopsy used to be mandatory. Most of these people were sick, that's why they died within the hospital. And I learned my mycology there from Dr. Arunaloke when he joined as an assistant professor, and later on obviously the CPCs where we used to see invasive aspergillosis everywhere, which we never thought in terms of it. And if you see it today, 42% of their autopsies are showing actually 8% was the incidence total. Roughly invasive fungal infections are 2.4% in these autopsies. Over a period of 15 years, they have done nearly 15,000 autopsies if you see it. That's a Trevor House. This is a big data which we are having here. 42% is aspergillosis, 22% candidiasis, And along with it, we are also finding, we used to see renal mucor, never saw that much as I saw there post-transplant renal mucor at PJ Chandigarh. Why I am talking much more in it, because this is important. That means the key remains the suspicion. You need to suspect it, you need to look at it, you need to confirm the diagnosis. And the hidden organs, when you are not able to pick it up, when we see it on autopsy, you keep on wondering what we did, why didn't we look at it. But there is also a spin-off is there, that you may over-treat them when it is not required. So like we are talking in terms of colonization versus invasion, we need to look at here also colonization versus invasion. These all are invasive fungal infections, the data which I am saying. I asked my Department of Microbiology to give me a bit of a data. This year we have sent 253 cultures, all pediatrics, neonatal one. 8% is our incidence, and we are finding nearly 58% Candida krusei at my institution. Rest is, that means non-albicans has taken over, and what was told to me has been the resistance to azoles, particularly fluconazole, as well as to capsofungin, which they have reported with the Vitek and Marditov, which is available to us now. So this is, they looked at it in the Europe also, when we said 570 episodes of ICU-acquired invasive candidiasis. What is very important for us to look at it, candidemia is, you see nearly 2/3 patients, and intra-abdominal candidiasis is very important. And we need to understand that it increases the mortality, it increases the day for which you need to stand there. And intra-abdominal candidiasis, all of us, wherever it is there, we need to be aware about it. Peritonitis could be there, abscesses be there, pancreatitis is one of the key factors, biliary tract is another one, and so are the peritoneal dialysis. Catheters, all interventions are there which are contributing, and obviously the mortality, depending upon the series, 1/4 to nearly 60%, which we are seeing in it. And if somebody has a septic shock with the candidemia, mortality goes markedly high. You can see it in this particular group. And what you will see, the risk factors is people more than 50 years of age has an intra-abdominal source of infection like perforation, peritonitis, or people coming with the pancreatitis. They are the people who tend to have much more male sex. You have a poor Charlson comorbid, you have a high index, and also if you are more in the intensive case, they contribute less in the general ward, probability of this less. And finally, what you are seeing is an ORIS. Remember, ORIS is, it's a worldwide alert. We are seeing much cases started from Japan. You have an antifungal resistance is inherently into them. Then you can have a resilience, they can stay in the environment. The implementation of infection prevention control is extremely important, and global surveillance is there. And I was reading an interesting report in a Science recently that they look at the pets which are at home in dogs. And when they did the cultures of the ear, they found that in 20% of the pets they found Candida auris in their ears. So you will see dogs commonly have a fungal infection. I don't know how many of you have the pets. I have 2 pets. So one keeps on looking at it, and there will be problem. The point I am saying is, the world today is of one health, where we need to look at our environment, what we are living with, and we be careful about it, that we can transmit the disease and we can receive the disease. So either way, it will work it out. So the diagnostic challenges in invasive are, you need to look at before positive microbiology. With the positive culture, whether it's a colonization or real infection, you need to look at a positive biomarker. It will take 5 more minutes. Then you have a differentiate true positives, etc., technical challenges, etc. That is what we need to see. So what is important for you? Whom to test, whom to treat? I think that's an important question. And culture-based traditional things, the definitive diagnosis you will see is when Candida species are identified in tissue specimens from normally sterile body sites, or if culture of a normal sterile fluid yields the organism. That's what we are looking at it. Biomarkers in serum and molecular identification has become a part. And what is very important is C. albicans, germ-tube antibodies, which we don't do it. But this, if you are finding it up, it will tell you look for alternate source or other source of fungal infection. Then you will get the positive blood cultures are very important. If you are finding that less than 2 blood cultures are positive, look for an alternate source. And again, differential time to positivity, mean time to positivity have no values, no cutoffs. But if you're finding two cultures positive, you can be certain of you dealing with invasive mycosis, and that's what we all look at it. So if not all blood cultures positive, look beyond the catheter, and you need to follow it. It's not that I have done it. After 5 days, again repeat it. They're finding it up that these cultures may be positive 14%. If it is there, look at metastatic disease or a complicated candidemia. So you need to look for them. And then similarly, another thing which is taking a big role now is the T2 MRI in the diagnosis of invasive candidemia. If you can do and find it out, it will tell you about complicated invasive candidiasis, and we need to pick it up. It is very important for us because otherwise sensitivity, specificity, most of the test is minimal, and also we realize it that probably that there may be because poor sensitivity, you may miss the diagnosis. That's why there is a discordance between the fungal cases seen on autopsy and clinical diagnosis. So this is something which was there, and if you find it positive in first 5 days, odds ratio of complicated is 37-fold. So probably now MRI have an emerging role in the diagnosis of invasive candidemia. Empirical treatment like antibiotics, if you delay it, mortality goes significantly. So if you have to have an ICU survivor, you suspect, treat early. But nevertheless, the principles of antimicrobial stewardship must be followed here too. Interpretations of BDG test results is also important. If you look at the American Thoracic Society guidelines which you practice, they talked about if you have 1,000 patients in ICU with invasive prevalence, candidacy prevalence of 10%, you will have 100 cases. 81 will give you true positive results. 90 will be false negative. 51 will be false positive results. So that is important. So you may be over treating it up. Therefore, the positive predictive value of one single test is only 19%. 4.9, that 1.9, that's when we need to avoid it simply on one, and negative predictive value is only half, which it means this test is useless as far as making a diagnosis is concerned. But when you start combining it up with two, then the sensitivity and specificity goes up. So clinical decision making, when you do it, has to be Bayesian. That means you have to think of clinical probability, and then you add these particular tests. Combination is much better, and same way you can use two ones if they are negative. Negative predictive value is extremely high. If BDG is negative and Kagata is negative, but unfortunately we don't do it too much. Practically you can rule out invasive candidiasis in these cases. As far as invasive aspergillosis is concerned, we are finding it much more on steroids, much more on chemotherapies, and much more these patients are having an organ transplant, but much lesser than that. This is a criteria which they're using it up. They're very complicated. Simple thing you should remember is that you need to look at galactomana. You look at PCR or a culture's positivity. If they are present together, these are the criteria. You can go and look into the book. But what is very important for the aspergillus PCR is that from any sterile site you pick it up. If you pick it from the lung, it has no value unless and until you show invasion or clinical radiological correlation is there. Then you will think in terms of it, not otherwise. Now this is again a kappa which we talked about, but remember one thing, this is what we saw with the COVID. Earlier we had seen it with the influenza also. What we should remember is the person is not doing well, is on ARDS, has a fever or a new shadows which are there. Probably if you are finding after 4 or 5 days still difficulty or secondary hit, please think in terms of just putting it up. Now, so when you are making a diagnosis of aspergillosis, you need to have more than one diagnostic method. One single thing will not explain. So you need to have two diagnostics. Either you do two tests, or out of them one should be, which tells you either about the antigen or the culture. Then we will go with it. Invasive mucor, again direct microscopic culture strongly recommend. Whenever we took, we straight away sent for KOH and we sent for the PCRs to pick it up early, and that's what we, and plus imaging. These three things are there, but no sign is definitive of fungus, especially mucor, unless or until we find pseudoaneurysms or we have an S sign. Then we think in terms, otherwise it is there. The histopathology is very clear. In patients of mucor, it will be non-septated and it will be usually at 90 degree. And that gives us the diagnosis and the final thing comes. And finally, one more thing you should remember is the breakthrough fungal infections. They are important, and if they come up, please think in terms of complicated fungal infections, or you think in terms of biofilms. If the biofilms are there, then there is no role of azoles. It is only echinocandins and nothing else. Or you may have a sick patient, you start with the liposomal amphotericin B. We are a poor place, so we do use amphotericin deoxychelate also. That is readily available, but nevertheless look at the kidney. If somebody has a kidney disease, then liposomal has no role. That is where either you will go for POSA or isovaconazole or deoxychelate. This is how it is practices. Now, antifungal resistance I have talked about, global fumigators is there. So there are only 3 drugs which you tend to look at it here. If you see, 3 drugs are azoles, echinocandins, and your amphotericin. Though 4th is there, number of them are coming in the same group. And if you have to do it, the drug of choice today is anidulafungin, which is there. It is better than capso, it is better than myco, it is better than voriconazole and other things. So in invasive candidiasis, this is now becoming a primary drug. And removal of catheter, please remove it if required. If you cannot do it, then probably you need to use amphotericin more than anything else. Again, there's no difference between amphotericin deoxychelate, though use it, has a lesser mortality, but toxicity is more. Therapeutic drug monitoring has been added up to voriconazole because what people are realizing, the toxicity and the drug interactions and the levels. So if somebody is there, we need to think about it. And then survival, no difference between isovaconazole and voriconazole, huge difference in the cost, which is there. POSA and voriconazole, again, no difference, which is there. And in mucormycosis, source control is important with preferably amphotericin. If that is not available, go for isovaconazole or posaconazole. At Rohtak, we had more than 500 cases of rhinocerebral mucor, which we treated during COVID. We started with an amphotericin B, did a source control, and after giving around about 2 grams or so of liposomal, sometimes we had a challenge also, but average later on 1.8 was there. We shifted over to posaconazole for 3 months and then repeated it with the MRs and CTs. So antimicrobial stewardship is the key. Please look at it like you have it. And summary is that it is increasing. We need to be aware about it. You need to go with the pre-test probability and then order the test. Need to know the limitations of the test, and probably we need to start treatment early, and like other, we need to de-escalate quickly. Thank you very much for the patient today. Apologies for jumping by 8 minutes. I thought Sumit is not there, so I can take the time.
So we tend to see
definitely there was a fear before we had sensitive test. As you said, it's a 43% mortality in cases of catechism. Still, the most common cause of fungal infection are set up this manner. So once you have started doing the sensitivity, you have realized that most of our patients are because azole nascent, so that they are still sensitive to azoles. So definitely that has decreased the role of echinocandins and liposomal amphotericin in our ICU. So I believe sensitivity, having even fungal sensitivity, it increases our mind. It broadens our mind in a way to look forward for antibiotic exposure. So this is makes exchange of such valuable experience. I thought I just say having sensitivity, having fungal sensitivity in ICU setup actually helps. It reduces the cost of the patient, and as a community as a whole in see way towards antibiotic exposure.
Very rightly said, Ruchi. What we are looking at is sensitivity was, we could never imagine 3 years ago. Now with the multi-top mitates available, you get the growth relatively quickly. And then along with the Vitac, you are getting the sensitivity. That has changed a lot of these things. Like at our place, it is in the pediatric and neonatal. That's why it is a little scary. And what we found is we have much more. That means again we will go with the same set of things that we go institution to institution and see. What I have been told by my microbiology colleague, Dr. Barul, is that nearly 56% are they are NAC actually. They are not Canada applicants. It's a and out of them it's a crucite. If it's a crucite, it is inherently resistant now to azole. So you are left with no other alternative but to use the kind of candidate. But on the other end, where is the candidate applicants? Because when you have to start a clinical therapy, if in my institution or in your institution or the place, if more than 20% of we take that as a kind of mark for the antibacterial, if I extrapolate it there, you need to start it up, but then you need to de-escalate azole difference there. And major challenge in azole also is fluconazole. It is not voriconazole as much, or posadol if the cross had come down again and gone up. But nevertheless, we need to have those assets. I absolutely agree. There is no point of difference there, and that's how we need to move. We need to practice further, and now in the coming time, the biases in the same fashion as we are using antibiotics.
So, thank you, Dr. Dhruv. Extraordinary presentation and a lot of cognitive things to learn from you. I just wanted to share 2 or 3 perspectives attached to this presentation. One, I agree with Dr. Ruchi because partially, because even in our setup, when you receive the patients who are quite nascent and nay, and especially when they're not get spoiled up by the bad antibiotics policies, majority of the times in our setup also we find them to be responsive to azoles. I think this is more of a problem with the patients, the profiles, where the patients has been exploited with the antibiotics, and then they become, they qualify for the echinocandins or maybe the lamp in that scenario. That is something which I have seen, especially when I moved from the Middle East to, the different setup where I'm working right now. So I find that majority of, in fact, the patients where we give them antifungal, that is mainly azole based, and they respond to it. Having said so, there's another thing which I wanted to share with you. There's no doubt that we also feel that the your fungal sepsis is increasing like anything, because just a couple of days back there was a case of ILD which got admitted with us. We were quite confused whether we are dealing with acute exacerbation of ILD or there's an infection which has sets in. As an early propagator of bronchoscopy, we did the scopy and we discovered the patient was having an X0 hilum fungal infection. Now this is something which I've never seen, at least in the last 15 years, never heard of. So the kind of fungus which we are now isolating, they're very different, and I'm sure that after the mucot, a lot of new surprises they are going to be sets in. So
with the molecular diagnostics going up, culture techniques better. So you're trying to pick it up, and if you do the separation, because IIT patient I won't be surprised as a steroid or as a tablet
yeah.
or something else.
Yes, exactly,
So,
exactly.
So they're significantly immunosuppressed, and that's what I'm not surprised at. It is there.
Maybe you are a pulmonologist and I'm the intensivist, so that is why. So that is one.
Nevertheless, the point is very well taken. But end of the day, what is important is we need to sit down with our microbiologists, we need to sit with our hospital administrators, and we need to sit with an administrator like my procedures of the infection control. Because one of the very important things in the ICU and hospitals, actually, wife agree with me, is that the basic conduct ducts are not cleaned up actually. And they are a huge source of fungus which is there. And the HEPA filters which we think will otherwise take care of, or the other filters. So you see the amount of this and the closed environment, you are constantly being exposed. That they are finding it as one of the common factors which is there. When we looked at PJ Chandigarh, what is the reason we are seeing so mucopollution here? One was the Department of Mycology was there. That was one part. Secondly, we realized a lot of construction activities were going on. So they tend to pick it up at that point of time, the fungal infections also. But nevertheless, huge use of, large amount of use of antibiotic, other things, we are putting up, we are giving the right soil for the fungus to grow. I think that's it.
Thank you, sir. Thank you for
Thanks so much.
Thank you so much, sir. May I now request our Chairman, Medical Oncology, Dr. D.C. Doval, to kindly felicitate the speaker of the session, Dr. Dhruv. Dr. Doval, sir, please. Thank you, sirs. I would now request our Director Lab Services, Dr. Anurag Mehta, to kindly step on stage and felicitate our chairperson for the session, Dr. Ruchi. Thank you so much, sir. Thank you, ma'am.